these studs or projections we utilize for the dental rehabilitation. It was not a new technique, but yes, it has been started in the year 1940. The first surgeon, the Swedish doctor, Dr. Gustav Dahl, who has first tried this technology to restore the dental rehabilitation in the maxilla. Later on in 1948, Norman Goldberg, who was the US Army dentist, who has tried and did some modification on the same implants, and he has first termed this implant as a subperiosteal implant for the dental rehabilitation. But they have not stopped there. There are a lot of other surgeons who have tried on a different occasions, but the maximum literatures and maximum what you can say the evidences of subperiosteal implant with modifications has been put forwarded by Leonard Linko in between 1960 to 1970. So they have a lot of articles from the 1940 up to 1970 and after that also. But unfortunately, this subperiosteal implant doesn't got that kind of a reputation so that it can survive for the longer period. But unfortunately, they have lost this reputation and has been discontinued. The reason of discontinuation is first and foremost thing it is the poor fit, because they have taken an impression on the bone after reflecting a flap, and on that cast they have fabricated with the help of a casting procedures. Definitely the material what has been used at time was not the titanium, but the chrome copper, many other alloys has been used. The stress shield effect, because of this stress shield effect, is to get fractured many a times. Bone resorption has been seen a lot of time after the procedures, thereby making the implant more mobile after the resorption. The second reason why this type of implant in the ancient or a olden time or a old concept, they used to not fix the implant on the bone, but they used to just sit over the mandible or maxilla, and they used to cover with the soft tissue. Unfortunately, due to the non-fixation, they used to get mobile and they used to come out from the jaw. Second thing, the problem was the soft tissue exposure. The implant is to get exposed, where you can see in the pictures here. The implant is to get exposed into the oral cavity, thereby creating a chronic infection, and implant is to get failed. So these are the certain problems where, because of which it has been discontinued from the utilization. So that's why. Parallelly, on the other side in Europe, Professor Enamar was doing some research on titanium cylinders, and he found some what you can say that most attractive results of the cylinders that is got osseointegrated into the bone. He utilizes that concept, and he, along with other researchers, they have developed the endo-osseous implant. From that time till date, we are very much what you can say that we're very happy to use this kind of an endo-osseous implant for dental rehabilitation. And we till now there are a lot of research on various type of endo-osseous implant, and it is still be a gold standard for any kind of a dental rehabilitation in edentulous patients. But yes, there are certain problems has been faced because of the resorption or some sort of a bone quality or quantity of a bone available. So again, the same endo-osseous implant has been modified either in a placing technique or in the sizes and the shapes of the implant. So if you don't have enough bone in the posterior region in maxilla or mandible, or nerve is very close to the crust, they used to tilt the implant, and they developed a concept of the same endo-osseous implant by placing two tilted implant in either side of the bone, thereby giving a concept of all-on-4. Sometimes they used to use all-on-6 kind of implant. Even if it is further resolved, they used to try and engage the implant in the zygoma, and that's why we call it as an accord zygoma implant. Furthermore, there are certain new techniques in placement of implant. This we call as a tilt concept, wherein we use all the implants in a tilted manner to engage the cortical plates of the the jaw, and we get a good results. But definitely, it's not possible in all type of cases. If you see the first case, there is a totally resolved matter. Yes, this case can be treated with the help of a zygoma implant, but there are certain cases where we see that even the zygoma is very thin, or it will not give enough support to the zygoma implants. If you see in the second case, the mandible is totally resolved. You can't place a single conventional endo-osseous implant. So these type of cases are really challenging for every surgeon or a clinician to for a dental rehabilitation. So what we can do with this kind of things? So definitely we have to think of giving over the mandible instead of going the endo-osseous thing. So that's why we gave again try to give a new concept to the old age dental subperiosteal implant. So what is difference between the old age and our new generation dental implants, subperiosteal implant? That is 100% not the same what we used to see in a conventional or a old age subperiosteal implant. Definitely these implants are utilized. Previously these implants has been manufactured after taking an impression of the bone, but now we utilizes the CAD/CAM technology. The CBCT DICOM data has been converted into a STL format, on which we utilizes various type of a software to create a design over the STL software, STL file. For that, we can give you a perfect fit, precise fitting of the implant over the bone, proper screw fixation if you wanted to do, so that we can avoid any anatomical structures in the areas either in the maxilla or mandible. Definitely, the material what we have chosen this time is a grade 5 titanium, which has got an improved stress steel, and definitely it doesn't have a possibility of infection if you give it proper sterilization protocol followed after the manufacturing. So these are the advantages of the material side. Also, we have tried the inner surface of the implant to give a hybrid surface, what we call it as a SLA treated. Sometimes we do hydroxyapatite layering or plasma spraying on the inner surface, so that to achieve a osseo integration of the subperiosteal implant. Also, we added some more addition to the conventional subperiosteal implant, that we have a two type of components of the subperiosteal implant. One is an endocrystal, that is the component of the implant. If you see in this picture, the abutment part or the small implant kind of a thing, so the endo-osseous kind of a structure which goes within the bone part of the alveolar crust, and we have a connectors which holds this and short implants with the help of a mini plates and screws. So that is the new thing. Previously, the old age implants is to only sit over the jaws, and the most important thing is that it is prosthetic driven. Before we used to take impression, we used to develop the as subperiosteal implant on the bone, but here we can reverse engineer. That is, first we can give a dental rehabilitation in the proper occlusion, and depending on that tooth structures or the tooth future processes, we can customize or we can design our subperiosteal implant. The outer surface we keep highly polished, so that it will not be irritating to the soft tissue over the implant. So these are the major difference. Again, the designing part, the fixation principle is similar what we do it in a facial bone fractures. In mandible, we follow in fracture fixation or orthodontic surgery, we follow this Chamfy's line of osseo integration, because these are the most stable part of the mandible, wherein we can utilize for the plate after the mandibular fixation. So similarly, we have taken those fixation points for our subperiosteal implant, so that it will not have any kind of loosening or any kind of trajectories. That's a bone pressure dissipates easily onto the body of the mandible. Similarly, in maxilla, we utilizes the buttresses, either the pyriform buttresses and the zygomatic buttresses. If it is a full arch rehabilitation, we take both zygomatic buttress as well as the pyriform aperture or a pyriform or anterior buttress for the fixation, which we follow for the mid-face fracture. If you see, the implant has been designed in the same pattern. The anterior pyriform aperture has been used for the fixation of the subperiosteal implant, and posteriorly zygomatic buttress. So these are the principles what we utilize for the fixation of our subperiosteal implant in maxilla. Let's talk about the basic components what we have incorporated in our subperiosteal implant. So one, this is the most important part, wherein we can get a screw retain prosthesis that we call it is a short implant. The new terminology for a subperiosteal implant is that short implant quick with microplates. So what I will explain you, this is the short implant, wherein we have internal threads for the screw retain prosthesis, which goes within the part of the alveolus. That's why we call this part of the implant as a subperiosteal or a endo-osseous part of the subperiosteal implant. And we have a connectors with which it is been attached to the fixation plates. These are the micro plates, goes either on the anterior buttress or on the zygoma buttress for the fixation of our subperiosteal implant. And finally, we have a fixation screw. Again, here the innovation what we have added is these all the screws are customized, and we have a separate dimension of each screw, particularly if in anterior we have a short screws, in the posterior in zygoma we have a longer screws. As per the requirement, we have a different sizes for the fixation. Even on the palatal we have a connector plate, so it has got a good stability once it has been fixed properly into the either of the maxilla or mandible. This is how the mandible designed. If you see, the chamfer line of osseo integration has been considered while designing, and all those screws come on the same chamfer line of osseo integration. So apart from that, the endo-osseous part of the implant. So whatever we do on a software that is called, we call it as a virtual planning, and how to transfer that virtual planning onto the reality, so that we can get a proper fixation of our implant into the either the maxilla or mandible. So we have a specific guide specific guide is being used to create those endo-osseous components to sink inside the bone. So this is the guide what we use it for the creating a trough or a crater in which the endo-osseous part precisely goes without any hassle. This is how beautifully the implant is supplied in a sterile box. We have a sterile box in which the implant is suspended inside the box. We have a fixation screws. Let me tell you about the screws. We have a fixation screw yellow, the regular screws which we use it for the regular fixation. In by chance we lose any screws, we have an emergency screws also, so that we'll not have any kind of a problem while performing the service. We have a specific for the fixation of all those implant into the oral cavity, right from creating a trough. We have a round bar. We are for drilling. If you have utilizing any kind of an endo-osseous implant, along with this, we have a specific drills for that particular endo-osseous component to be create a trough and endo-osseous inside the bone. We have a fixation screw drills and the drivers for that screws, and we have a multi-unit driver as well as the internal hex driver for the fixation of abutments. So let us see few of our cases. This is a resorbed mandible. This is how it is interlacing. If you see, there is a totally resorbed mandible here in this first picture. Second thing, we have exposed the thick full thickness mucopascal flap has been raised from the mandible, and implant is been fixed after creating a proper position trough for the endo-osseous component of the implant. And finally, the implants has been sutured, and after 8 days, if you see, we have given an initial temporary processes after the initial and some sort of whatever the soft tissue healing happens. After that, we can give even you can give after 72 hours, 48 hours, we can give a initial temporary restoration for this kind of an implants. This is one more case of our the maxilla. If you see, this is a trough where the endo-osseous component goes after the trough created into the maxilla, and it has been fixed on the zygomatic buttress anterior piriform aperture. There's the very the very sound bone for the fixation of subperiosteal implant. If you see, all the screws has been properly fixed, and there is no gap between the implant as well as the bony surface. So the precise fitting of implant and passive fitting of implant is very much important in subperiosteal implant fixation. This is again mandible. Immediately after 48 hours, 72 hours, initial temporization, the modified dentures, hybrid dentures can be used for the initial rehabilitation. Later on, whatever the clinician comfortable to give processes for it. This is again one more case of a maxilla totally resorbed, fixed subperiosteal implant, mandibular. Immediately after closure, after 4 or 5 days, you can see nice healing around the implant abutments. This is a mandible. After 10 days, we have taken the impression, the open ray technique, and a hybrid processes has been made and it has been delivered to the patient. This is how precisely we can do our subperiosteal implant in a severely resorbed mandible or maxilla. This is post-op X-rays of the same cases. You can see how precisely it is sitting. There is no gap between the bony surfaces and the implant. All the screws are within the bone. There is no chance that screws will go into either the sinuses or it can damage the inferior alveolar nerve. So all these screws are planned very well before the starting of designing. So this is one more case of a resorbed maxilla. Yes, of course, many people ask us, why can't we do all-on-4, all-on-6 kind of a dental rehabilitation for such mild features? But when we see the X-rays or CBCTs, there is hardly any bone is left within the inside the soft tissue. If you see this, definitely you will feel there is enough amount of bone is left inside the soft tissue, and we can definitely go ahead and do some sort of an endosseous implant. But unfortunately, when we open up and see, there is hardly any bone, very thin, paper thin bone is left in this area. If you see, my endosseous component also is not totally inside the bone. It is just on the mesial and distal aspect of the abutment. So these cases are definitely difficult for any surgeon to give a conventional endosseous implant. Yes, of course, it can be done with lot of modification and bone grafting, waiting period. Definitely, the patient has to wait for the longer period, about approximately 6 months to 1 year for to get a complete or a fixed prosthesis. But in case of subperiosteal implant, immediately after placement of subperiosteal implant, you can immediately give this kind of a denture, and patient is very happy to have a teeth immediately after the procedure. Though definitely the patient don't have to wait for the longer period for the process. Again, this is one more case of our where the surgeons, this is not my case, but definitely this is our BONEEASY case. What I'm presenting here, the reason for presenting this case is that already all-on-4 concept has been used for this case. 2 zygomas has been placed and 2 anterior inclined implants has been placed for the dental rehabilitation. Unfortunately, 1 zygoma has failed and 1 more implant has been failed. But once any of these endosseous implant fails, the same processes will not be fitting for will not fit, and definitely we have to do something for such cases. So we have planned and we have fabricated this kind of things, and whatever implant is healthy apart from the conventional zygoma or anterior implant, we have left as it is, and we have not utilized those implants, and we have not even removed, and we have placed the subperiosteal implant and gave a dental prosthesis for such cases. This is immediate post-op X-ray of the subperiosteal implant after the placement of implant in the maxilla. This is how exactly the implant is seen after the placement within the CBCT. If you see, all the screws are far away from the inferior alveolar nerve, and that is the beauty that we can already decided or plan during the time of planning while designing the implants. One more case of dental rehabilitation, lower arch, definitely all-on-4 kind of dental prosthesis has been given with the help of endosseous implant. Maxilla, definitely the maxilla was totally resorbed. If you can see, hardly any bone in the posterior region. Even in the anterior region, hardly any bone for endosseous implant or all-on-4 concept. So decided to go for a subperiosteal implant and fabricated, planned and well planned and fabricated, and we have given this processes for the. It's not only for the full arch cases, but definitely we have certain cases wherein you have either the posterior maxilla, posterior mandible, or sometimes even the anterior maxilla or anterior mandible severely resorbed because of trauma or any pathological condition. Coming to this case, this is a case of maxillary cystic macular cyst this patient had, and he has undergone a surgery in the maxillary anterior region. Unfortunately, he has lost all of his anterior 5 teeth, plus he has also lost the anterior premaxilla. Hardly any bone is left in the anterior region. For such cases, if you wanted to do dental rehabilitation with the help of an endosseous implant, you have to wait at least for around 1 year, and still you don't know whether we can give such kind of a vertical height with the help of grafting. the chances are very less. You have to do a lot of magic in such cases to get a dental rehabilitation. But yes, these cases can be solved with the help of a subperiosteal implant. This is how we have planned. If you see, we have taken the anterior buttocks as well as the palatal part for the fixation of our microplate. With the help of these microplates and the connectors, we have two endo-osseous implant, subperiosteal short implants incorporated along with the subperiosteal component, and we have fixed with the help of either side the screws on the pyriform aperture as well as the palatal seal. Initially, after healing, within 24 hours, we have in-house milling of a graphano and even a dental prosthesis, and what we call it as an initial temporization of these cases. So patient is very happy. Post before he leaves the OPD, our clinic or an office, we can in-house give him the total solution for the dental rehabilitation. Again, one more case of a mandibular posterior region totally resolved. The nerve was very superficial and no choice except the subperiosteal implant. Definitely bone grafting and waiting for 6 months to 8 months, still hoping for the good results. We can go ahead and do this kind of dental rehabilitation with the help of an endo-osseous implant. But it's again time taking, and the options are not very clear that we'll get a success in that scenario. But yes, with the help of subperiosteal implant, we can give good results. This is how it is. If you see in these sections of planning, the nerve is very superficial and it's hardly 3 to 4 mm. You can't place any implant in that area, and if you have to give an endo-osseous implant, either you have to add at least 6 to 8 mm of vertical height to the mandible. Then only it is possible to give any kind of a endo-osseous implant. So patient don't wanted to wait for so long and still hoping for best result. So we thought of giving him a subperiosteal implant in this case. So this is how it has been designed. All the screws are planned so that it will not damage any way along the path of subperiosteal implant to the inferior alar nerve. So this is how it has been supplied, and it has been fixed precisely and passively onto the mandible. So this it is intraoperatively. This is the marking where the trough has to be created for the passive setting of our abutment. This is how the abutment looks, and this is the post-operative X-ray of the implant after the placement of implant on the mandible. Again, one more case of a partial subperiosteal implant. Here, if you see, has hardly 3 to 4 mm of bone is left. Endo-osseous implant, if you try to go inside this and try to fix it there may be chances that the implant may fail, will not hold enough on the mandible. Definitely, so we wanted to have something where we can get a good result. So we thought of giving this case a subperiosteal implant for the dental rehabilitation. This is intraoperative picture. This is post-op X-rays, just to see what is the situation of our screw and where exactly it is going and whether it is damaging or it is close to the nerve. So precisely done. Again, one more case of a maxillary anterior region totally resolved. This is how it was intraoperatively seen. There is hardly any bone, and whatever amount of bone is there, it is not of a good quality, so that we can utilize and give endo-osseous implant. So we thought of giving a subperiosteal implant. So this is how immediately after the fixation of our implant, how it looks. After 10 days, this is how the abutment is seen, and initial processes even before the sutures are removed, we have delivered this processes, and patient is complication. What we have seen is some areas of the plate has been exposed, or sometimes the endo-osseous component of the implant has been exposed and screw loosening. All those things are there. But yes, that can be manipulated. That can be easily corrected with the help of a minor surgical procedures without removing the endo-osseous implant or the prosthesis. We can solve all those problems without much complications. So coming to the advantages of subperiosteal implant, Yes, of course, it is less invasive surgical procedures compared to any other invasive procedures like bone augmentation procedures. Definitely, it adapts to the existing anatomy. You don't have do much modification in the jaws to, for example, for an endosseous implant, we have to tilt the implant. We have to go all the way up to the zygoma, maxilla, and nerve lateralization. So we don't have to change the anatomy. We can 100% respect whatever the nature has provided, and with slight modification we can do justice to the patient. Single surgery is needed. No other surgical intervention is needed unless until any complication. But yes, when we compare with bone augmentation or bone grafting kind of procedure, we need at least 2 to 3 surgeries. The initial surgery for the implant placement along with the bone grafting. Sometimes it may fail, so we have to do for the second surgery endosseous implant to be exposed after the bone grafting. Then we have to place a abutment. So all those things are there. But in subperiosteal implant, we don't have to go again and again and do the surgical procedures. Definitely, it allows immediate loading. There is a lot of other techniques wherein all on 6, all on 4, we can do immediate loading, but 100% with subperiosteal implant, we can immediately load these cases. Less psychological impact on the patient because you don't have to go again and again for a surgery. And also you can confidently tell the patient that once it has been done, it is done. You don't have to come back again for the re-exploration or any kind of a re-surgeries for failures. So that is more what you say that pleasing to the patient when we talk about bone grafting and other procedures. It favors stabilizations and osseointegration of the structure. So the new additions to the subperiosteal implant that it get osseointegrated, not only the screws what we are using for the fixation, but yes, the implant itself, the entire framework get osseointegrated because the inner surface what we have in added to this new technology is the rough, sandblast, acid etched, and sometimes we even add up few patented products to get more osseointegration, and definitely no waiting time. Yes, of course, nothing is free from complications or disadvantages. Complex design protocols, it is definitely time taking, but yes, that is nothing to do with the patient. It is on the virtual side. It takes a lot of time designing, manufacturing, post processing, etc. Need surgical skills. Definitely, it is not just to open up and place or something, but we need a good surgical skill right from the flap designing up to the closure and the skill of fixation of plates and screws. Extensive micropestle flap has to be reflected. That is a major disadvantage when we compare with the endosseous implant. Little complex than the regular endosseous implant, but results are very favorable when we compare with the any endosseous implants. At the end, I would like to say, definitely the more number of cases has to be done with the subperiosteal implant to get more and more innovative ideas so that we can be incorporated in our designs and give the best result for the hopeless cases. Definitely, it is very, what you say, it's very easy and very, what is it, precise and perfect outcome when we utilize this subperiosteal implant for the dental rehabilitation. So that is what I can give you. And it's if you are doing endosseous or any kind of an extensive surgical procedure for implant placement, then definitely for you it is an easy task to utilize this concept and give a solution to your patients. Thank you very much. And I would like to acknowledge my team, Rui, Barbara from BONEEASY Portuguese, Dr. Rabia, who is always there arranging things for manufacturing to logistics and other components organizations, and my professor is Dr. Swapnil Pandey for always being there to solve all my cases with prosthetic rehabilitation. This is my team, operating team. We always operate together and to give the best solutions to our patients. Now, with this, I would like to thanks, and hopefully I would like to open the session for question and answer, and whatever your questions are there, I'll be happy to answer. Thank you very much. Over to you, Aditi. Aditi, I'm done. You can open up the question and answer session.
So I guess I have some technical glitches on my side. Just give me 1 minute. Are you able to hear me, sir? Can you hear me?
Yes, we can hear you.
Yes, I can hear. I can hear you.
Okay. Can you exit and join, please? Yeah, thank you. Hello, Doctor.
Hello.
Dr. Aditi, I request you to rejoin, please. Thank you.
I'm sorry for the technical glitches. And thank you so much, sir, for this amazing session. And I hope every person would have learned something new today, this evening. And before starting the question and answer session, I request all the participants to kindly drop their questions in the question and answer the questions one by one. And before moving on to the question,
Dr. Aditi, we are not able to hear you.
I hope my voice is clear.
Yes.
Clear now.
Okay, perfect. So I'm really sorry for the technical glitches, and thank you so much, sir, for this amazing seminar. And I am sure that each and every practitioner would have learned something new, and everyone is just delighted. So before moving on to the question and answer session, I request all the participants to kindly drop their questions in the question and answer box so that we can take up questions one by one. And before moving on to the question and answer session, I have one small presentation about the organization, and I'll be introducing our organization to all the participants. Just a sec.
Dr. Aditi, if you find any difficulty in PPT, please, without PPT, you can continue. Thank you.
Okay. I'm really sorry for the glitches. Okay, so anyway, our organization is Dentistchannel Online with the motto "Healthy Smiles that lead to wealthy lives," and we welcome you to the second World Virtual Implant Expo 2021. In 2020, we had the first chapter, and it had been recorded in the uh, Indian Book of Records as well. So after the huge success, we have come with the second chapter, and we have 40 plus stalwarts of implantology with us this time. And basically, our organization is a leading dental media company that aims to spread awareness and knowledge regarding various aspects of dentistry. And we conduct regular webinars and courses on the different aspects and areas of dentistry. Being a Prime member of Dentistchannel Online brings you several opportunities, accredited webinars, and dental courses. So I request all the participants to kindly subscribe to our Prime membership, because after that you can avail a lot of benefits, like you will be getting certificate which is accredited with more than 30 CPD points, and it is certified from FDA Germany. And kindly be with us, because tomorrow as well we have a lot of sessions awaiting. And you can follow us on Facebook, Instagram, and YouTube using our links, and the links have been provided in the chat box. So you can go through our links and you can catch all the recorded videos. If you have missed out something on the live session, you can go back and again watch the recorded videos anytime. So you can follow us on Facebook and Twitter and YouTube for the recorded videos. And our sponsors, you'll be seeing one small video. And okay, so moving on, sir, can we move on to the question and answer session now?
Yes, please.
Okay. So I'm really sorry for all the tech. Can you hear me? Is my voice audible, sir?
Yes.
If Dr. Aditi, if you still have issues, I request.
Is my voice audible, sir?
Doctor.
Yes, I'm clear.
I think Dr. Aditi has issues. Dr. Abdul Hameed can read out direct question from Q&A box.
Okay. So first question is from Dr. Amit. He's asking, how much is the longevity?
How much is the longevity? Hello.
Dr. Abdul Hameed, can you read out question from the Q&A box?
I'm not seeing any questions in my list. I have only one question in my question answer chat I can see.
Okay.
Aditi, can you ask me again?
I'm really sorry, sir. So there was one question by Dr. Amit. He was asking, what is the longevity?
Longevity of the implant.
Of the implant.
Yeah, we have experience of about more than 6 years now, and we have completed in India. We have completed around 75 cases of subperiosteal implant, more than 75, and last 1 year we have completed 50. So our experience of previous and till today is a maximum what I have an experience of around 6 years. But yes, the number of cases what we have done is more than like around 60% cases is around 3 years maximum. So, so my maximum experience with my implant is 6 years plus, and internationally, the company whom we are working, we have experience of around more than 8 years. In India, yes, maximum 6 years.
So I hope Dr. Amit has got his answer. Okay, moving on to the next question is from Dr. Vidya. She's asking how much is the magnetic mallet and sin crystallizer? Okay, this question seems to be incomplete.
Not related.
No. Okay, so all right, I request all the participants that whatever questions you have given us, we have noted it down, and we will try our best to reply and get back to you very soon. So sir, before ending the session, do you have any housekeeping, I mean, I'm really sorry, any note for takeaway note for the participants?
Yeah, no, I think so. There is one more question from Anamika Gupta.
Actually, it's not appearing on my screen.
No, yeah, that's what I'm saying. There's some questions. This Anamika is asking, would CBCT is sufficient for the digital impression? See, digital impression and CBCT, I am little bit confused about the question, because CBCT is sufficient for digital impression. What kind of an impression we are talking? See, yes, of course, CBCT will give you all the data for model fabrications. Okay, you can convert your CBCT data with the help of a DICOM file into any STL format for a to get a model of any of your subject. Like if you have a DICOM CBCT data of a mandible, with the help of this CBCT data through the DICOM file, you can convert your into a model. So I'm not sure what kind of impression you're talking, but yes, a lot of things can be done with the help of a CBCT.
Okay, so are we done with the questions, sir?
Yeah, so at last, I would like to thanks once again Dentistchannel Online for giving this great opportunity, and I'm always very happy to share this innovative technique with all these people because this is very new, and a lot more people are aware about this technology and things that many people are doing it. And that's the reason why I always thanks to Dentistchannel that they give this kind of an opportunity to share some kind of innovative techniques and things that is easily reachable to the maximum audience. And so they also get to know more about these innovations in the field of dental implantology. Because I know there are a lot of people who are practicing implants, they might also not be aware about these things. And definitely they might be denying these kind of a patient, saying that we can't, even they tried by conventional ways, and unfortunately, and they say that this is the maximum what I can do. But yes, the technology has reached to that level. You don't have to say no now. You can give options. Yes, there are a lot of people who are working on these techniques and technology, and you can utilize this amazing technology not only for dental implantology. Yes, this conference or this entire symposium was on the dental implantology. So the scope is only about the dental implant. So we have discussed only the dental implantology. But yes, furthermore, lot of things can be done with this technology. We are doing total mandibular reconstruction, maxillary reconstruction. The entire face can be reconstructed with the help of this technology. So I would request all the participants who are seen or who are attending this seminar, they should go back and they should see about this 3D printing technology. And you can connect me, or you can ask the Dentistchannel. They can take down my connections through the mobile number or through email ID. You can whatever they will definitely provide you people, so you can connect with me. I can help you out whatever your queries even after the session. So I would request all of you to go through this technology and try to utilize this technology. All the best. Thank you very much.
Absolutely. Thank you so much, sir, for taking out your precious time from your busiest schedule, and hope to see you very soon, sir.
Yeah, I think so. There is any other questions? Can you just check it? Cost effectiveness. Mushtaq Hakim is asking me. Yes, Dr. Mushtaq, definitely this is slightly costly, but when I compare all-on-4, quad zygoma, these things, then definitely is almost similar with 10 to 15% extra cost. But what I can say in terms of cost, that if you do any like quad zygoma or any other things, if it is successful, then it is fine. If you lose any implant, then definitely you have to redo everything, the things. But with this customized implant, definitely entire procedure is not going to be waste. Any small complication that can be rectified easily. So when we compare with the cost, definitely it's a cost effective.
Right. So there are 2-3 more questions regarding digital impression cost to inculcate in private sector, and how much is the cost. Basically, I mean, the basic questions they are asking about the cost, that
Yes,
what should we ask.
Definitely it is a little costly when compared to any conventional things. Anything which comes in the technology and people are not using to that extent, definitely is the initial stage is a costly, because if you remember zircon caps or any kind of this caps, which when they launched, they were like very extremely costly, because very rare DMLS crowns, if you see, or any zirconium. Initially these caps were very too costly. Now because more number of people are using, then definitely the things becomes cheaper. So similarly, it's hardly like in 1 month or 2 months we are doing 1 or 2 cases. My entire machine has to work for that one implant. So it's very cost effect. It becomes very costly when it is like one pieces has to be fabricated. But definitely when it becomes like I have to fabricate 10 implants at the same time in the same duration of time, my cost will be divided into 10. So definitely, if people start, more and more number of people start using this, definitely it will come down to a cheap.
Right. So thank you so much, sir, for taking out time from your busy schedule, and hope to see you very soon. And thank you so much for being with us.
Yeah. Thank you to our DCO, and congratulations once again for your records. And I wish this year also you do something amazing. Thank you very much.
Absolutely. Thank you so much, sir. Thank you to all the participants, and thank you for bearing my technical glitches as well. So with this, we are ending today's session, and we'll be looking forward for your participation for tomorrow's session. Thank you so much, and have a great evening ahead.